As introduced, Amanda, I'm part of the team at the Division of Urology down in Cape Town. And, it's quite a pleasure to be the first speaker of this first semester. Today, I'm looking at discussing pathophysiology of ureteric obstruction. Now, I intend to do this is just to introduce the topic, touch a bit on the etiology, how it relates to the clinical presentation of these patients, and then I'll go into the physiology ureteric peristalsis and how that is affected. And then we look at complete obstruction, partial obstruction, together with that recovery of the urinary system post-obstruction. Then we'll discuss pathological features. It is what we call it more of a basic science topic. At the end, I use the slides just to relate it to clinical practice, so that this morning we can take something as we go towards our different clinics. So clinic this side of Cape Town. So first and foremost, unilateral ureteric tract obstruction, defined as a mechanical or functional impediment to the flow of urine. This is from the renal pelvis, ureter, into the bladder. If there is an obstruction in that tract, this is upper tract, the lower tract, whether this is mechanical or rather functional. If there is no flow, that is an obstruction. And if what call it limited to one side, that would be unilateral. Of course, if bilateral, we'll discuss that as well, which is bilateral ureteric obstruction. Usually also can manifest in embarrassment of urinary function. Then we'll speak of unilateral obstruction in a solitary kidney, which also more behaves like a bilateral ureteric obstruction. And of course, the classification dealing with this disease entirety always goes from your approach will always be looking for your causes. Of course, will always be congenital or acquired, causes being luminal, intrinsic, or extrinsic. Just in terms of how prevalent this is, only the data we have does indicate that obstructive uropathy accounts for about 10% of your renal failure cases, and an autopsy series they showed about approximately 60,000 neonates to geriatrics were found to either have unilateral or bilateral obstruction, and it is estimated to be at about 3.1%. With a predominance in female of pregnancy age and those with gynecological malignancy. So your age group tends to be 20 to 60 years, and in males we find it's more prevalent in 60-year-olds owing to prostatic disease or bladder outlet obstruction of any sort. And in children, it tends to be more in males, and particularly of those of less than 12 months age, and then that tends to relate to your PUJ. What you call it, prevalence, which correlates to that. I've just put in this here, not to discuss, but just to put it to everyone that there's a multitude of causes as broke down in our approach, congenital, acquired, intrinsic, extrinsic, and luminal, that can cause this disease entirety. Today, for this talk, we're not focusing on any of these, but we are focusing on the actual disease process, the pathological changes, and how one should respond to that, or how one should extrapolate this data and apply it to clinical practice. So in terms of presentation, what does affect is that one should be able to elicit whether it's acute versus chronic, whether it's partial, this is complete. And again, as I'll go into the talk, whether it's unilateral or bilateral, because the disease process tends to be different. And of course, the presence of infection affects the clinical picture, affects the pathophysiology process, can worsen the effects, and then of course, if you break it down to age, you're looking at antenatal, childhood, and adults, different sort of clinical presentations, different causes. At the end, when I finish the talk, my final slide on thoughts, I use the same slides to round up the talk, and you'll see how it relates to our clinical practice. So in terms of unilateral ureteric tract obstruction, as I've said, depending on duration, which is the key factor, the longer the duration, the more the decrease in potential for reversibility of tubular regrowth or repopulation. And we see this in that structural or functional changes may persist post-relief. So it's very important for colleagues to be mindful that we have time periods, time markers that offers an opportunity to reverse disease, and to regain function, and certainly structure, which will go on more as we continue to talk. But I want you to note most of the data or most of the information we'll be talking about today is extrapolated more from animal study, which is why they are put a human kidney and a pig kidney and a rodent kidney. And certainly the work which I'll reflect on this morning is taken from the studies in rodent kidneys, in which they divided UTTO to RUTTO, 1 to 7 days, de-obstructed the rodent, and 7 to 14 days made it an RUTTO, which is a recovery of unilateral ureteric obstruction. How they did this was by tying those ureters, leaving them tied for 7 days, development of pelvic calcium dilatation to hydronephrosis, then at 7 days, releasing that leaf and doing a reimplantation, then following up these rodents, putting slides under microscope, and then certainly seeing the changes noted, which is what we'll go into. I put the pig one in the middle because there was very much work done in piglets, comparing it to human kidneys, and certainly the guys in the shoulder are here, published in 2021, that they tried with brain. They looked at brain dead patients at 72 hours. Reimplanted them with piglets to see if they any regain function using the piglet kidneys for renal failure patients. And that work is promising, something in the pipeline for us all to look at as our donor transplants. Very long, very long. So in terms of your physiological periodic peristalsis, what's important to note is that you've got propulsion of urine from upper urinary tract to lower urinary tract, and this is an active process which is mainly dependent on your pacemaker cells, which are set in the pelvic calcium system, and these are your interstitial cells, like of Kajal, and this depends also on your elongated calcium channels, which then form your initiate the depolarization process, which is set to very low. Start the peristaltic movement, and then with adequate mucosa coaptation through the smooth muscle cell in the ureters, you get peristalsis. And it is said that the ureteric part is at rest, and then the pelvic cervical contraction forces a bolus of urine into the ureter, and while it's at rest, what's important for you to know, as it propels down into the bladder, the bladder pressures remain lower than your ureteric pressures, and hence you get the ureterovesical force, or rather contraction, expelling urine into the bladder. And then and then this is just a reflection of what resting ureteric pressures are as they relate to an obstruction in which they will be set high. So your resting ureteric pressures normal of the 0 to 5 centimeters H2O, with peristaltic waves normally at 20 centimeters H2O, with a resting potential of minus 32 millivolts. And as I've said before, the depolarization here is much lower. The frequency of contractions are 2 to 6 minutes, very low compared to the key fibers in the heart, which are at much higher rates than this. And what's important for us to note is that at low flow urine rates, that renal valves contractions, as I've said, are always greater than ureteric contractions, and that this is what allows you to get the bolus of urine coalescing down the ureter. But in higher flow rates, the resting potential contraction instigates a myogenic transfer into the ureter. This means now the ability of the ureter to co-opt and form those waves dissipates, and then urine flows as a column, and hence we can get dilatation from that as no longer one gets the ureteric function. I bring this slide up and as the neurogenic control of the ureter, as we'll see when we type things up at the end. I think it's a very crucial one, particularly the distal ureteric peristalsis and obstruction thereof. It is said that distally the ureter has this stimulatory and inhibitory channels, and mostly being cholinergic and alpha adrenergic being stimulatory, and the inhibitory one, two peristalsis, being beta adrenergic. Then this becomes a PowerPoint slide, or rather high-yield slide, especially for management of distal obstructions, which are partial or which can be successfully managed. As we know, partially you don't get what you call it regress of a full peristaltic segment. You still get peristalsis. So, in summary, the obstruction effect on peristalsis with complete polyps, you get increased ureteric pressures by 7-fold, increased amplitude, and most importantly, aparastosis. That ureter never move. Whatever is blocked, it will never come out. And with partial obstruction, you get reduction in contractility by approximately 50%, increased amplitude as well. But what's good here to note, and hence with the previous slide, is that you still get continued peristalsis, and hence one could excite those peristaltic channels to ensure whatever intraluminal blockage or obstructive cause is there could be expelled or egressed. And this is now the meat of the talk, pathophysiology explained. I'm going to differentiate the main characteristic features between your unilateral, as promised, bilateral, in your unilateral solitary kidney, which behaves the same as your bilateral. And most importantly, for us to all note, here the key thing is that renal pelvis or ureteric pressures is where the changes are renal blood flow and glomerular filtration rate. So the hemodynamic changes are actually aimed at maintaining the glomerular filtration unchanged. Unfortunately, the kidney does get embarrassed to the rodent studies have shown. And then they've also demonstrated to us that when unilateral behaves differently in that you get a triphasic response, which I'll go into. And when bilateral or when dealing with a solitary kidney, the response tends to be biphasic. And these are key features to differentiate the two. And we'll go on into the meat of the talk. So I've put in the glomerular filtration rate formula here so that we know what pattern to eat, what changes affected by the kidney, by the body, in trying to maintain that glomerular filtration rate. And just for one to know, the KF is the glomerular filtration coefficient, the glomerular capillary pressure being PVC, and and then your hydraulic pressure within the renal tubules in your PT, and your oncotic pressure of proteins also is in the formula, which reflects glomerular capillary and efferent arterial. And important very much to know that the GC depends very much on the renal perfusion, which is calculated from your aortic pressure minus your renal valvular pressure over renal venous resistance. You get your renal perfusion flow, which correlates, I want to say directly proportional of, or rather, your PTC depends on, and hence, with the next slide, I speak to the afferent and efferent contraction of vasodilation in trying to maintain the GFR. This is the first slide, or rather graphs, a graphical representation in unilateral ureteric obstruction. Here, the first one on top shows us the mean left ureteral pressures. The one at the bottom shows us the mean left renal blood flow changes. And this is now in a unilateral obstructed ureteric system. And this is the triphasic response they speak about. And what it shows us there, that from 0 to about 90 minutes, you get this rise in your renal blood flow and in your ureteric pressures, which continues for about 0 to 90 minutes. And the mean pressures are increased, colleagues. So as you can imagine, the ureter is blocked. So the pressures increase within the system, and the feedback mechanism into your calyceal system, you get calyceal dilatation there. And then what then happens, the body tries to maintain the glomerular filtration rate. And by this now, what it does, the contralateral kidney, which is confined, will secrete your prostaglandin 2, which is a vasodilator. And then you get this inducible nitric oxide, which will then act on your afferent in an attempt to maintain glomerular filtration rate. And then after 90 minutes or so, which GFR still maintains because of the contralateral kidney, that is change in that the mean that ureteral pressures persist to go high, but then you get the mean that blood flow coming down, and then that is mainly due to the fact that at past 90 minutes you get a vasoconstriction of your efferent, and this is mainly because the vasoconstrictors now are secreted, mainly due to the endothelium injury and the secretion of endothelin, and because it's inflamed, you get thromboxane, which is also a potent vasoconstrictor, and then you get these changes. Then at about 5 hours or so, you will then get again endothelin being your potent one. You get vasoconstriction now of your afferent arteriole, and hence at the third phase of unilateral ureteric obstruction, you then tend to get a decrease both in left ureteral pressures and in renal blood flow. This is just in words what I've just explained. It just tells you that the increase in renal blood flow and ureteric pressures as a result of the other. Why would believe that the glomerular filtration rate will then fall rather than GFR? But as I've said, you get this vasodilator inducible action from nitric oxide and prostaglandin E2 from contralateral kidney, which prevents that fall and maintains it. And then in phase 2, as I've said, which lasts up to 5 hours, the decrease in renal blood flow is continued while the ureteric pressures remain high. And hence, the following slide will tell you about how the calcium system I was talking about, especially in the acute phase, starts to get embarrassed, you get egress of urine there, higher sinusoidal, we call it, but I'll show you in the next slides to come. And keep to note here in the tension 2, the one I forget, so better with thromboxane and endothelin as the main vasoconstrictors. Phase 3, you then get a decrease in renal blood flow, decrease in ureteric pressures, and as I've said, afferent and afferent arterial constriction will give you that result, and then the decrease in GFR. And the chilliness said to be the key vasoconstrictor, but angiotensin 2 and thromboxane as well. And then you get adaptation of dilatation through lymphatics and venous channels as well as the urine redistributes. But venous and lymphatic channels tend to be involved more in a chronic picture, whereas your calycia or your pilocytus tends to be involved more in your acute picture. And yes, yeah, and after a day or two or more than 24 hours, you will note that more than 50% above baseline ureteric pressures will remain. They will never fall back to normal baseline pressures. So key differences now with the biphasic response mainly is that you get modest increase in renal blood flow, but with marked ureteric pressures, and renal blood flow is increased more to the renal cortex, but reduced in the juxtamedullary regions, whereas with the unilateral ureteric, this is the opposite of that. There's not a focus of blood into the juxtamedullary or inner cortex, as opposed to what we see in bilateral or unilateral obstructed solitary kidney. And in the phase 0 to 90 minutes, what is important to know is that afferent arteriolar dilatation is more induced again by inducible nitric oxide. But here, because you don't have a contralateral kidney that's functional, you don't get prostaglandin E2, but get the platelet activated factor. Phase 2, which is more than 90 minutes, you then see the decrease in renal blood flow, continued increase in ureteric pressures, afferent dilatation, marked increase in afferent vasoconstriction. And this is mainly due to the fact that you get atrial natriuretic peptide, which is secreted by the cardiac enzyme and is not excreted now because you don't have a functional contralateral kidney. And this has 4 main functions which embarrasses rather the renal system. In that, number 1, it inhibits the tubulo-glomerular feedback, because now you don't get your macular dense sensing the less sodium and being able to respond appropriately, and inhibits sodium chloride absorption in the ascending loop of Henle, and also inhibits the vasopressin-mediated water permeability, and also promotes diuresis and natriuresis to develop persistent or rather maintain vasodilation of that afferent arteriole, which you don't see in your BUO, which is your bilateral ureteric obstruction. Because if you remember in the third phase of unilateral, that afferent also gets vasoconstricted. This is a graph, or rather a graphic of form of just what I've said now. The table above is the same one that I've discussed, but I just wanted to put it in comparison with your bilateral ureteric obstruction. You can see there you don't get the third phase, which means you get persistent vasodilation of that afferent arteriole, maybe due to your ANP, which is not excreted by your contralateral kidney. And then what that means is all the four effects I've explained in the previous slide. And this is just nice, sort of, what would one say, constructed, it's not a table, but rather summary, I should call it, of all these changes we've discussed. Gives you the key players in your unilateral zinc nitric oxide, especially, and especially your first phases, and compared to the other side where you get more your platelet activated factors. I won't waste time saying the same thing, but let's move on to partial obstruction. Here, effects are variable, depends again on severity and duration of obstruction, but tends to behave the same, but in that it is more forgiving. You get renal blood flow decrease and GFR decrease in its lateral kidney, whereas compared to your chronic partial obstruction, there is a decrease of renal blood flow up to 25% of normal, and again, a shift of blood years from outer cortex to inner cortex that is maintained, and then the degree of renal blood flow obviously declines depending on the obstruction or rather severity of obstruction. Similar role players in terms of your vasodilators and acting on that afferent arteriole. This is a nice slide just to summarize the ingress of urine, the setting of obstruction. As I've said, the sinusal, which is the calicial one. Number 3 there is usually your first, especially in the acute phase, where your pyelolymphatic and pyelovenous tend to sort of be a mark of sort of your long-standing chronic obstruction. But you get 5 mechanisms in which the kidney can egress urine: pyelotubular, pyelointerstitial, pyelosinusal, I should say, pyelolymphatic and pyelovenous. Power slide, this one. Effects on tubular function. We've just got to remember that the ascending loop of the distal collecting tubules are very much vulnerable to ischemic insult, and this then affects, especially in your ascending loop of the ability for sodium reabsorption, together with that water following, and then in your collecting tubules, the potassium acid substitution is impaired, and this is mainly simply because you've got loss of energy dependent reabsorption, which mainly occurs via your potassium, hydrogen, or sodium, potassium and hydrogen 80 phases. And once you don't have that energy dependent reabsorption, it does not occur. Ophthalmic proximal tubules and glomeruli are spared. And one of the defining features between the unilateral ureteric is that you don't get hyperkalemia or post-obstructional diuresis. And this is again in respect to the fact that the functional contralateral kidney gets rid of most of the solids, being ANP, and in bilateral we get an increase in serum ANP. And then in that setting, we see post-obstructional diuresis and natriuresis that do occur, and again link it to the pathophysiology colleagues is the persistence of that arterial vasodilation. Spectroscopically, what do we see in 24 to 48 hours? You can note that the renal pelvis and ureteric obstruction do occur. and one can diagnose it with imaging, and we'll see dilated kidney. By day 7, the gross swelling and the edema of the kidney continues, and if unabated on these rodents, we certainly see that it continues up to 3 months. Then chronic changes starts to take effect. In that, you now get what we call it markers of chronic inflammatory changes, loss of parenchyma, fibrosis owing to infiltration of extracellular matrix, with loss of breakdown of it, and then the build up. There's a reduction in size compared with the contralateral kidney. And it's not just a reduction in size, because the snag kidney that's affected gets more, but also you get this compensatory renal growth of the contralateral unobstructed kidney, which was first described by Kidman in 1943. More work has been done towards that. We now know it is more of a hypertrophic compensatory and a hyperplastic, in that those tubules grow in size, but it is not a hyperplasia. There's no increase in size or in nerve folds. You still remain with the same number of nerve folds, but they are bigger, they are longer, and they are much more functional. And in terms of microscopic changes, the pattern here follows that. Number one, you get tubular apoptosis, which causes the increased pressure that's transmitted to the renal tubules, stretching the cells, activating the renal angiotensin system, which, as I've explained in the previous slide, together with tumor necrosis factor, will cause tubular apoptosis of renal tubular cells. And this is seen within hours of obstruction having set in. But of note, glomerulus is relatively spared early. In the 21 days, when we follow this road, and certainly we recognize that disappearance of renal tubules occur. So, I mean, one then uses these days as markers of when to intervene and when not to let when one can still recover function in the kidney. Then it progresses then to tubular interstitial inflammation, with your pro-inflammatory chemokines again being TNF, which continue to recruit inflammatory cells, predominantly the macrophage, and the macrophage is to secrete more chemokines, and then this later leads to also tubular cell death, more as a result of ischemia, oxidative stress, and of course ATP depletion, which will cause renal tubular death. Of note is that once tubular interstitial fibrosis sets in, it is said that it is irreversible and that renal function will be lost, even post obstruction, even if you release obstruction of that system. But they say all your TNF, your NFF, will still remain high, even with release at 14 days. Post-obstruction. This is just again the dramatic form of what we've said, that it goes from tubular damage to inflammation to fibrosis, and this process is a 21 plus or take process in which these cells then start undergoing irreversible change or irreversible damage once we get very much extracellular matrix turnover, which is high, and with no breakdown of the ECM. I've just put this one just for what they've seen under the slides, in which there you see that tubular interstitial fibrosis is set in, vascular sclerosis, glomerular sclerosis. By this time, colleagues, you're not going to get any reverse in function. Bit recovery. It's mainly influenced, as I've said, by I'll run over the slides, by duration of obstruction. Short duration usually equals full recovery, because your renal tubular cells are still able to repopulate the tubules, but you prolong it, you lose significant loss of tubular cells. As I've said, fibrosis sets in, you don't get reverse. And complete obviously is worse than partial obstruction. And of note is that there is data to suggest that in humans, unilateral ureteric obstruction, you can get recovery up to 150 days of obstruction. And here, this is the RUO, which they looked at the rodents, which I think is very nice to apply, in that any obstruction that's unilateral that lasts up to a week, you get full recovery of that renal function at 2 weeks post the obstruction of that system. And if your obstruction lasted 2 weeks, there's recovery of up to 70% at 6 months. And if you've got obstruction of a month, there is some recovery of renal function, but it's not significant. And 6 weeks obstruction in the unilateral system, you get no recovery, no renal function. So 2 weeks, at least in the unilateral system, that should be obstructed. And of course, in partial, it tends to be more forgiving. 42 weeks is still full recovery. And at a month's time, you get 30% recovery. And relief at day 60, you get about 80% recovery. At least the RUO, which is the recovery ureteric obstruction rodents, is shown as this. And in complete bilateral ureteric obstruction, this is the work done by Jones et al., which they looked at humans, not rodents, this time humans, and they looked at biphasic nature of renal function recovery following relief of chronic obstructive uropathy. Like an old paper, 1988, but this applies. With one man, they looked at his bladder outlet obstruction, and they noticed this phase of structural recovery, tubular phase, glomerular phase, and they noted that the first phase usually lasts about 2 weeks, and it's marked by your increase in urea, electrolytes, and water excretion, but that will improve in 2 weeks, and one can link it to the slides. This is now still in the pathophysiological changes that we don't have 8 phases to do any reabsorption, and then you get high sodium fraction excretion and lower absorption of water, and the lower phase improvement. We see improvement at 3 months, which means that the glomerular phase lasts up to 3 months. And we should be repeating these bars at 3 months' time to establish what kidney function you have post the obstruction. Of note that this study could not establish any relationship between duration of obstruction and recovery of function. Final thoughts as I round up the talk. You saw the slide before. This is more basic science stuff, but I wanted to link it to clinical. As I've said, antenatally, childhood and adults tend to present differently. Essentially, in the antenatal to childhood picture, usually the commonest cause will be a PUJ obstruction, which could be dynamic or mechanical in the form of a vessel that's crossing, and certainly the work done by Justin Howlett or rather and Lazarus et al. The abstract I can send you the link to also show that degree of obstruction doesn't stick to what function you have. They looked at the case series they presented on show that any 20 millimeters or up of pericocystal dilatation, you can still get 100% function there. And as you go up to 30, you start getting 52%. And as you get up to 40 millimeters, you start losing about 80% function. And adults, presentation adults is mainly from stone, is a common obstructive cause. Can range from asymptomatic to patients coming with multi-organ failure owing to a 7 millimeter calculi. So one needs to keep in mind that these patients could be different, and again, the anatomical imaging suggested to diagnose how functional I have to speak for it over time. And hence, I had thought the only good thing I'll do today is the first speaker is to keep in time. I might have over. Thanks, sir.
Yeah, thanks a lot, Dr. Masi. We just got feedback from Prof that the sound is not too great. I hope you guys had most of it because I tried logging on my phone. I could hear well. I hope everyone also had well. And thanks a lot to Ramasi with a great talk. I think we're going to have to try to keep up the energy because it was a very well prepared and presented talk. Any questions and comments from the floor? From anyone that has a question or comments? Okay. So there's a comment from Professor Kesner about the fact that if you have an infection on top of the obstruction, those timelines that Marcy was talking about, could be prolonged, and the prognosis is likely worse than someone who's got just obstruction and no infection. So that's quite an important thing to note. And just again to add first to what she's talking about, that's why there's always serious anxiety if someone gets unilateral obstruction, but they have a low GFR. It essentially is a sign that sometimes there's something wrong with the other kidney, because Marcy mentioned that initially the other kidney should be able to maintain GFR. The fact that then they get renal impairment, it may be a sign that there's problems on the other side. Obviously, we know that there's also dehydration causing problems on top of that and other things. I'm not seeing any questions or comments here in chat. All right. Okay, thanks to Goli there. Sorry, I missed that. How does specific gravity of urine help in evaluating post-obstructive diuresis? Dr. Masi, you want to come and answer that? A question from Kitso. How does specific gravity of urine help in evaluating post-obstructive diuresis?
Thanks, Kitso, for your question. As I've alluded to say, also what happens is, remember, you must take it to the pathophysiology. So this is what's key here. It helps you in that, remember the type of urine you get. Number one, you don't get the ATP phases working, which means you don't get the kidney function to concentrate urine, but to secrete what you call it, excrete molecules into urine. Then you get increased excretion of sodium with low molality urine, and then that then with the low specific gravity can suggest to you whether or not one is post-obstructive diuresis or rather another physiological process taking place. I don't know if I've answered that well. Thanks, Peter.
Thanks for your question, Kitso. We'll just swiftly move to the next speaker in the interest of time. So the next speaker is Nganyesi Sigasa, Senior Registrar, University of Cape Town.